everybody. Thank you so much for joining. I'm proud to introduce my friend and colleague from the University of New Mexico, Dr. Jacob Ormsby. He trained in Memphis and at Northwestern and is a phenomenal neuroradiologist who's won many teaching awards. He doesn't have a particular specialty. He can do it all: spine, brain, spectroscopy, functional MRI. And very good at procedures. So he's going to give you guys a really great talk, and we'll have some time for questions. I have nothing else really to say. Let's look at some tumors of the meninges. Go for it.
All right, thank you so much, Dr. Sorty. Real pleasure, and I appreciate the kind words. I also have to first off thank Health for the World for allowing me to do this. I think it's a great organization. There's lots of great things that they do. So I'm glad I can also be a part of this organization and help hopefully give back. So today we're going to talk about tumors of the meninges. And when I decided to do this talk, I was like, well, how can I actually make this exciting? I mean, Meninges, meningioma, that's about all I can think of. And yes, that is truly the only tumor of the meninges, technically. There are lots of mimickers, and we'll talk about some of those in the talk, but you know, there's actually some really interesting stuff with meningiomas. So, you know, hopefully everyone will at least get something out of this talk. So what I'm going to do is I'm going to take about the next 45 minutes to kind of just go through meningiomas and then hopefully have some time for questions. And I'm sure you'll have questions as I was putting this lecture. I started coming up with more and more questions that I can think of. So again, thank you, Health for the World, and I hope you enjoy this lecture. All right. So when I give lectures to my residents, I typically do it case-based. I just like going through a case, talking through it, trying to figure it out together, hearing people's thought processes. The unfortunate thing with this type of talk is I can't hear what people are thinking. So I'm just going to actually be talking with myself. So you'll kind of notice as we go through some of these slides, I put in my own stuff that I'm talking about. So we're going to start off with a mystery case. And the thing I say here is, what the heck is this? You know, this is something ugly, big tumor here. It just looks funny. And we'll come back to this at the end after we've learned about meningiomas and what they look like. And then we'll decide, is this a meningioma or not? So let's kind of just keep that in mind as we go forward. So, all right, so what are going to be the objectives for today? I want to be able to describe findings on CT of meningiomas. We're going to be able to describe the findings on MR. We're going to talk a little bit about advanced imaging and other modalities that you might see meningiomas on, and you might think about. We're also going to try to gain some knowledge of the different types of meningiomas. Yeah, I did say earlier a meningioma is a meningioma, and that's actually not technically true. So we'll delve a little to that more. And then we'll discuss different locations of meningiomas and some of their mimickers. All right. So again, looking at a case, you know, first thing I might hear the residents say is, that's a mass. And I want them to be able to say, maybe a little more confident, what type of mass they think that might be. And there's some clues in the imaging to tell us what type of mass this is. And we can just kind of start looking through the different types of images and even this image to really say, oh, okay, now I think this is a, all right. So the first thing I'm looking at here is going to be these little speckles right in here. And if we go back to this, it correlates with these guys here. Now, it doesn't look like blood product, as blood product wouldn't be as dense as this. It looks more towards the bones. So these are calcifications. So this is already one thing I'm putting in my report, in my findings, and also in my head to start thinking, okay, what types of tumors have calcifications or can potentially have calcifications. So I look at that. Next thing I look at is still the bone. And what do I see next? Well, I see that there's some hyperostosis. And what does that mean? It means actually extra buildup of the bone. If you break down the word hyperostosis, more bone, and I can see that this is just too much bone here. So I'm already throwing out keywords in my head, in my report, to say, I think I know what this is. I think I'm getting there. Let me just keep on going on with the images, maybe see if I can find any more things to help seal the deal. And then what I'm still looking at the bones, but I put this on sagittal and I see something that maybe even more specific to tell me that, I think this might be a meningioma. I already have those two prior things kind of maybe leading me that way. But then I got something specific like this. And I know this is a big word, pneumosinus dilatans, but it really says it in the name, what's happening. So the aerated sinus is dilating. And you can see right here that the sphenoid sinus is actually being uplifted. And again, here you could also see that hyperostosis that we saw on the coronal image. And if you look very, very carefully, you can even see some of the calcifications there. So in the end, I say that's a meningioma, just even on a CT, right? I use my thought process going through there, and I'm looking at the CT findings, and I say, that's what got me to say this is meningioma. So I can be more, reliable on my differential. I went from that's just a mass to, oh, this is this type of mass, and it makes a difference for the surgeons. All right. So next, we're going to kind of move over to MR. Now, in MR, I think most people, when they hear meningiomas, they're going to think about things like the CSF cleft sign. And I'm not going to really delve on that because I think most people know that, or the dural tail sign. I'm going to go more into some of the types of sequences where you can see it, and so on. So we'll start here, and this is a T1 weighted image on MR. And the question is, well, they're saying there's a possible mass. I don't see the mass. And granted, yes, this is one slide in radiology in real life. We're going up and down, but I just don't see anything here. So I'll go over to maybe say my T2 weighted images. And look, I'm trying to find this mass. I don't see anything. What's going on here? Are they right that there's even a mass? Well, let me go ahead and look at some more images. Oh, there it is. So what image says this? This is a contrast image. And if we look close, it's right in here, right? And so meningiomas, we know, are very vascular, and on top of that, love to enhance. So really for MR, one of your big key image sets is going to be a contrast enhanced MRI to evaluate, to look for these meningiomas. Typically, they're going to diffusely enhance. Now, we'll talk a little bit later about some of maybe the different types of meningiomas, and they might not then at that time diffusely enhance. But for general thought process is, yes, they are a diffusely enhancing mass. All right, so if we go back to, say, our T1 weighted image, we can see the mass was right here. Well, it can actually be T1 isointense to gray matter. And there are certain subtypes that tend to make it more that way, but a lot of times you're just not going to be able to see it that well on a T1 weighted image, especially if it's a smaller tumor. The bigger it gets, the more conspicuous it can get just in general. Now, this is the same for T2. So for T2, you look at it and it can also be very iso-intense to say the gray matter. So again, you have probably the easiest way to look at them is having that post contrast. When they're small, yes, they can easily be missed. And you just have to kind of think through these. But again, it enhances diffusely. There's not too many tumors that are going to be diffusing, enhancing, and kind of throughout, especially when they're smaller. All right, so other sequences for MR, you can do diffusion weighted imaging, and it may show increased diffusion restriction. And I key on that word may show increased diffusion restriction because it's actually very variable. And it goes to that how hypercellular the tumor is. If we think about DWI, it's not just only good for strokes, but if we think about on a physics level, it really looks at water movement. And when something's hypercellular, I like to tell my residents, go back to biochemistry. Remember about osmosis? Well, when it's hypercellular, the water wants to stick around, so it's not moving at all. And that's why we're seeing on DWI this increased signal or increased diffusion restriction in the tumors. But again, depending on the subtypes, sometimes they can be more diffusive restriction or less diffusion restriction. So it can sometimes be a helpful tool in the fact that when you see it have increased diffusion restriction, you can go, this is pointing towards a meningioma. But the opposite can't be said is true, where if it doesn't have diffusion restriction, you can't just say, oh, no, it's not a meningioma. So again, maybe a helpful tool, but not always. All right, now what about flare? Flare itself is gonna be similar to that T2, so it can have the tumor look very similar to the gray matter. But what things can it bring out? Well, it can bring out things like perilesional edema. And we can see that all around this tumor, all this bright stuff here. And that's actually an important finding, not just for saying, okay, I think this is a meningioma, but patients will have more symptoms and are more likely to need to get the tumor taken out when they have this perilesional edema. So a side note on perilesional edema, what is it due to? So we actually don't know. There's some thoughts about what it could be. Some people think that there are specific chemicals that are released by the meningioma that cause a reactive process in the surrounding brain. Some think, oh, this is just simply due to the mass effect. And then others say, you know, I actually think this might be a change in vascular flow in the sense that you could have some venous engorgement and slowing there. It's hard to test things in vivo, so that's why we can't really come down with why is it being caused by the perilesional edema. Now, again, though, it is something I think you should look out for, and for telling your surgeon colleague, yeah, there's a lot of perilesional edema. This patient is probably having more symptoms and issues. You should probably get to them sooner. So, you know, I showed pretty much all our grayscale images, but what about cool color images that we can do, right? And so I can think of some things like perfusion. And actually perfusion can really be helpful. So let's show this case. So again, nice pretty colors over there on the image set. And what do we have? We have this area where it's like really focal, bright red. And then you have some more right here. And you can see on this scale here that whatever this means is that it's the highest. And what does it mean? So this is actually arterial spin labeling. It's a technique that we can use without giving contrast to specifically look at blood flow, one of the perfusion parameters. Now, if we did something like dynamic susceptibility contrast, DSC, if we did a CT perfusion, it would also show us similar characteristics. Now, arterial spin labeling in itself looks at blood flow, whereas when we do a DSC MRI or a CT perfusion, you can look at things like not only blood flow, but blood volume. And in this case, blood flow and blood volume do go hand in hand. So those are both going to be very intense on those imaging sets. There's even, you could do, DCE, dynamic contrast enhancement, which is a little more in the research realm, but some places do this. And that shows increase in K-trans. So again, other tools that can help you say, oh, this is meningioma. And why is there so much blood flow? Well, it goes back to the anatomy of a meningioma. They are just super vascular. And that's what we're picking up with this blood flow imaging, is all that blood flowing through that vasculature in that area. And so these are like just super, super intense. All right, so, for this one, here's the grayscale version of it. Yeah, I can definitely see that. But did it really help me on this case, right? This kind of looks like a meningioma based on the MR imaging that we talked about before, with the bright enhancement kind of diffuse. I don't know that it really helped me on that case. It's cool to see on arterial spin labeling, but But what about this case? And this is a very subtle finding, but it actually helps really point out that, hey, that there is a lesion here. So again, we look at our scale and there's this very bright red spot. And I know this is noisy, and this image alone, it's hard to tell exactly where I'm at. I can tell you this here is the cerebellum. And so to me, this is probably middle cranial fossa region. I have my grayscale, which may be a little bit better, right? Maybe I can kind of draw the cerebellum here, maybe a brainstem there, but that area is still sticking out. Well, you usually don't do arterial spin labeling alone by itself. So, I do have the other images to look at. I have my regular MR image. And in this case, you could see how it could easily be missed without that arterial spin labeling, in the sense that this is a small tumor. Now, granted, at this time, it might not cause an issue, but it might need to be followed up at this point. And, you're right next to the cavernous sinuses, which are also bright. So it's just another tool that we can use at our dispense to kind of look for these meningiomas. Now, we can also look at squiggly lines. I joke, but squiggly lines, when I talk about that, is going to be spectroscopy. And spectroscopy can be useful for evaluating meningiomas. And so we have this case here. Now, again, going back to thinking through this process, well, I told you meningioma is diffusely enhanced. It is for the most part, but you got this kind of central area here. The neurosurgeons weren't quite on board calling it meningioma as we were, and we said, hey, well, we could do some other sorts of imaging to maybe try to figure this out for you, because for them, when they're thinking about their approach, it might change things, right? So we said, what about doing spectroscopy? And so, yeah, that's exactly what we did. And what's great about spectroscopy in meningiomas is they have some characteristic findings. And that can help you kind of further decide that is a meningioma there. So if we look here again, yes, it looks like squiggly lines, but once you start to understand what all these little letters, numbers mean, it starts to really point out at you. And then, yeah, there's this huge peak here, and this is probably the most important. So we'll talk about that in a second. But besides this big peak, there's also some other clues and findings here. So one thing is this myonisitol right here, the label there is pretty much non-existent. Now, what is myonisitol? Myonisitol is a glial cell marker. We tend to see it when gliosis is around, but also it tends to be elevated in low-grade glial type tumors. So this is saying, yeah, there's probably no glial cells in there. Next thing we're going to see is this marker here, NAA. And it's pretty darn low based on this integer too, if you compare it to the others. And NAA is a neuronal marker. Well, meningioma should not have any neurons in it, so it should be pretty low to non-existent. Now, I will tell you, this might be actually falsely elevated because there are some other little metabolites that can also be in here, including glutamate and glutamine. And glutamine are actually markers for meningiomas, but it's going to be this peak again that's going to be our one that tells us, yep, that's meningioma. So again, this peak is alanine, and it's a very big peak going on here. Now, alanine. So alanine is pretty specific for meningiomas. It's part of the Krebs cycle. Do we know exactly why meningiomas tend to have more? From what I know, no, it's not very well understood. It sits at about 1.4. So if we kind of go back here, if I count my little dashes, 1, 2, 3, 4, and I draw a line straight up, what? Yep, it's right there. And one thing to know is that on a short and long TE, so if you were to use like a TE of 30 or a TE of 270, those are going to be going up. Now, if you use an intermediate TE, say somewhere around 135, then it actually gets inverted. And so that is actually something you have to know if you're going to do spectroscopy, which TE are you going to use? And each has their benefits. So this one here was actually a short TE, and short TEs are better for picking up more metabolites, but they also tend to cause more noise. So it's a balance that you're doing there. So again, this one is a short TE. But we had a similar situation come up for this one. It was, again, I think it's a meningioma. It's diffusely enhancing, pretty well circumscribed, in the ventricle, around the ventricle, not completely sure, and, I said, I'm not gonna show you dural tail sign, but you can't use the dural tail sign here because there's no dura next to it, right? So again, it's okay to maybe question this a little more, saying, is this a meningioma or not? And patients present with different histories, so it can kind of leave some things open sometimes. And so for here, we also did spectroscopy, and it's actually showing very similar findings. And the difference here, though, is this is the intermediate TE. So this is at about 135, and you can see this inverted kind of peak, or I would have to say trough, right, in this region. But again, kind of pointing to it. One other peak that you'll notice that's relatively high is choline. This is really just a cellular marker. They are very cellular in general. So that's what it's showing here. Tumors themselves in general tend to have elevated choline. All right, well, we can also think about nuke med, and sometimes we see that on there. So, you know, if we think about nuke med, you're reading a bone scan and you say, well, what's that right there? There's some asymmetry in that skull. What's going on there? And we kind of then go to, it would at least have you go to say, I need a CT. Well, our next image set, we get a CT and we're like, oh, okay. Definitely asymmetry. But if we think about the things we talked about CT, well, hey, there's some hyperostosis there. Can there be some other things that look like that? Yeah, and we'll talk about that a little bit later. But I'm already thinking, okay, this has a possibility to be a meningioma. Let's go to an MR. Let's do the post-contrast MR. And what do you know? Yep, meningioma here, but it's also actually extending throughout all of here. And this would be a transosseous meningioma. And for those that have a good eye, there's actually a secondary meningioma on this side, but meningiomas themselves can have some increased signal on the bone scan. And you'll notice here when you saw the other side that there actually is hyperostosis there. I don't know that the bone scan points to it all that well there, though. All right, next case. I'm actually working backwards on this case, but it's because you know, I want to kind of walk through this, show you like, oh, in retrospect, yeah, there's something there. So, you know, this is a contrast enhanced MRI. Again, probably our best one to use for looking for those pesky meningiomas, right? And this patient just also happens to have neuroendocrine tumors, and they get a special PET scan, and there's something there. It's just bright. You know, is it artifact? Is it real? Well, let's look at the source images. Oh no, there is definitely something there. That is super bright. You know, that there's something going on. And so if we look back at our MRI, it's actually right there. And again, you might make the argument that, well, it's so small, what does it matter? Well, at least knowing that meningiomas can be seen on these nuke medicine studies, it helps you reassure the patient and also know to then follow these up. So what nuke medicine scan was that exactly? Well, this was a gallium-68 dotatate. And this is actually a newer PET agent, again, that we're using for neuroendocrine tumors. And why does a meningioma also do this uptake? Is it a neuroendocrine tumor? Well, it actually has to deal with a specific receptor, and I don't expect anyone to remember this receptor. I'll probably forget after I do the lecture, but it binds to SSTR2A receptor, which is actually a specific marker in meningioma. And what's great is neither bone nor brain are going to have this receptor. So again, it's going to be bright in a dark background. Now, there has been actually some research, since people have seen that meningiomas are lighting up on the scans, to see if there's actually any clinical use for problem-solving cases when you're trying to decide is that a meningioma or not, to actually use gallium-68. So maybe we'll see this in the future. It's just another tool in our tool bag to say, oh, okay, I can use that to figure out that's a meningioma. All right. So I kind of
Hey,
alluded.
Dr. Ormsby, there was a question in the chat actually about one of your images 2 slides ago.
Yeah.
So maybe it's halfway, 8:30, so maybe a nice time to pause. So why
Sure.
not fat saturate the MRI so that we could see better?
So that's a great question. It's hard to know ahead of time that you should fat stat the MRI. You could do it in all your patients, but sometimes for these MP ranges, which give great volumetric and have really been the workhorse for looking for things like tumor, you don't typically fat sat those. And I don't know that fat saturation, say in this case, is going to be all that helpful, because if you're going to fat sat something, it really needs to be a mass surrounded by fat, right? And in here, it's next to that cavernous sinus, which also enhances. So it's just going to be hard to see. And I don't know in this specific case that it'll be useful. Now, if we actually go to this one, yes, we did do fat saturation, and it's because we knew about the transosseous potential component, and we were actually looking, was it extending outside of the borders? So great question, but in this case, I don't know that it would specifically help for that. So, right. So, the next question, are all meningiomas the same? And the answer is no. I'm just going to put that out there. But there's different ways to look at this. Now, if we look at the WHO classification, and this one's actually a little bit outdated, and I actually did that on purpose, you'll see that there's just a ton of tumors out there. This is just CNS region tumors, and it's a lot, right? It would be hard to be able to name all these. But even meningiomas, if we look at it itself right here, there's actually a ton there, right? And there, in fact, there's about 15 different types of meningiomas. And you can see here, they range from clear cell, angiomatous, plasmatomatous, some words I'm just never going to use. And a lot of this is really on the histological level. And for us, in the imaging purposes, for the most part, a meningioma looks like a meningioma, looks like a meningioma. We're not good at telling the difference between these different types. Now, I will say there's some that are going to have more calcifications, some that are going to be more plaque-like, some that are going to be more round, some that have a higher potential to be a more aggressive type meningioma. But there hasn't been great research to show that you can definitively choose which one it's going to be. I think it'd be a great research project to maybe do even deep learning with, to see if you could be able to tell the difference histopathologically and correlate it with our images. But as of right now, we're just not good at that. Now, there was an overall grouping of these, and the old grouping was that it was either run-of-the-mill meningioma, atypical meningioma, or anaplastic/malignant meningioma. And in the old grouping, you could use the histological subtypes to put these in certain groups. For instance, if you had a rhabdoid and or a papillary one, it denoted that that was an anaplastic meningioma. And in the old grouping, you could also use Roman numerals for WHO grade. And just by the way I worded this, you can tell that has all gone out. That's not stuff we do anymore. So now there is officially in the 2021 WHO classification, only one type, though there are still those multiple subtypes. Again, the papillary, clear cell, those type of things. We no longer use the terms atypical or anaplastic. Instead, we're just going to term them by their WHO grade. And you can see, I also purposely wrote on here Arabic numbers. So again, they've gone away from doing the kind of Roman numerals and now gone to doing the Arabic numerals, just because they thought there was more confusion or potential for more confusion with the Roman numerals. So again, can we tell the difference between the types? Yeah, again, some may calcify, some are more dense, but imaging really not reliable. Different subtypes are known to have propensity to be in different locations, and we'll talk about the different locations in a sec. But it is pretty well known that that transosseous is going to usually have different markers and everything compared to, say, our anterior skull-based one. So you still can have image findings suggestive of WHO grades, but you cannot really say, oh, this is definitely a WHO grade 2 or WHO grade 3 just on imaging alone. And my basic thing is the uglier it looks, it's likely a higher grade. And so what do I mean by that? So if we take this one here, it's ugly, you know, but kind of to me more the run-of-the-mill, diffusely enhancing. So to me, a grade 1. And again, ugly is probably a gestalt. But what I really mean about that, it's pretty uniform. You know, no tumor is a good tumor, but it's just got well demarcated borders. I don't see anything that would make me think this looks aggressive. Now we get to this one. This one looks a little uglier. And how does it look a little bit uglier? It's got kind of this more cystic necrotic area down here. I'm seeing more heterogeneity in the enhancement. And one thing we talked about earlier was hyperostosis on CT, dealing with the bone. And that means that the bone expands. Well, here this is actually invading the bone. So that's not usually for your run-of-the-mill WHO grade 1 meningioma. So yeah, this one looks uglier. And these are all path proven. That was a WHO grade 1, the first one. This is a WHO grade 2. And then this one, again, probably the ugliest. It's a WHO grade 3 meningioma. It has this cystic component, but it's not a true just run-of-the-mill regular CSF. We can see that it's kind of murky. It probably has some cells in there. It's got some more necrotic areas here and there. So again, it looks a little more funny. It has some of the characteristics of a run-of-the-mill meningioma, but this ended up being grade 3. And that's really the best we can do pre-surgery, is to say, yeah, this one looks a little more suspicious that it's going to be a higher grade. Now, some people have said, well, why not use diffusion restriction? A lot of times, the more hypercellular a tumor is, the worse it is. We see that with GBMs. We see that with meningioblastomas. Both of those are WHO grade 4s. Could we use that? Well, I took the images of our 3 masses that I just showed you, and this is actually the WHO grade 1. And to me, that has the highest diffusion restriction compared to these others. And they all have some. So diffusion restriction is not a reliable marker for actually trying to help with grading this tumor. So you can pose a question, is it even important to know the grade? And yes, I do think it's important to know the grade. And this likely comes, you know, it helps let the surgeon know ahead of time. but even when you're doing follow-up, I think it's important to know the grade. And for me, the biggest thing is it helps me with pre-test probability. Any case that I look at, I've already gotten the history together. I've maybe looked at prior imaging, and I'm in my head doing a pre-test probability saying, what is the likelihood that I'm going to see something on this exam? And the higher the grade, the more likely there's going to be reoccurrence. So I need to really like say, okay, maybe I slowed down when I get to that area where the resection was and really look hard to see, is there some residual tumor there? Is there recurrent tumor? The other thing with knowing the grade, it does help direct management. So for both your grade 2 and grade 3, they will get surgery and usually radiation also. And knowing that's a higher grade, you might follow it a little closer. So, you know, WHO grade 1, after a while, you could probably just watch it every year and so on. But some of these higher grades, like a grade 3, you might start off watching every 3 months or every 6 months just to make sure you're really getting a handle of it. Now, one question I can think posed of here is, what about WHO grade 4 meningioma? Well, they actually technically don't exist. The World Health Organization says there will never be a WHO grade 4 meningioma. You could have the worst, ugliest one, but it's only going to be a grade 3. So, so the next final probably area that we're going to talk about is where can meningiomas be found? What are the different locations? And, you know, I alluded that knowing the locations, they will have different propensity to be the different histologic subtypes. Well, the majority are going to be supratentorial. And on top of that, majority have a propensity to be around the dural sinuses. And this has to do with the cells in the area, the type of arachnoid cells, the peel cells that are in that area, that just has a propensity to not only be supratentorial, but also to be around those sinuses. And one thing you have to watch out when it's near those sinuses is, does it invade them? This is an important thing to know when you're talking to your surgeon colleagues. It might mean that they're not able to get all of it, and they're going to already know ahead of time that there's going to be some residual tumor there. So things to be aware of. Now, they can be intraventricular, and we saw that one that we figured out with spectroscopy that is intraventricular. Way we can see that this is intraventricular. You can see the ventricles actually widening here on the compared to the contralateral side. Now we also have things like transosseous, and we saw a good case with nuke medicine earlier. Here's another case where you have the tumor centered right here on this sphenoid wing, and this one actually is extending outside extracranial into the soft tissues here and into the orbits. And this is an issue in itself because it's causing pretty good proptosis here. So this is another common area that you'll find them. They can be anterior central skull base, and this was actually the one that we looked at earlier with the very first case, the one that we saw right at the anterior skull base, and what I used for both the CT and MR. So a very common location there. Other locations that you should think about, though, are along the optic nerve. And this one, to me, is actually a little bit harder, but you can see it, and our ophthalmologists are great doctors. They'll probably have some thought that, oh, there's something going on there. You guys need to check it out. And that's why we did this fat set here to really look at this area. And you can see that there's asymmetric enhancement throughout. Now, this is my one and only video for the talk, but I thought it was cool to show. So this is the same case looking at that optic nerve, and it's really going to show you this is what a meningioma does along the optic nerve, and this is what it looks like. So yes, this is just a little slice, and it is in the axial plane, and I'll get to the actual image here. And so just to orient ourselves, this is the globe here. This is the optic nerve and optic sheath. But if you look very specifically, this dark area itself is the actual optic nerve. And it's all this here that's surrounding here. So this is the optic nerve sheath tumor surrounding the optic nerve. And this is what we call that tram track appearance. But again, it's hard to kind of see that tram track appearance just on this alone. So sometimes thin imaging can be of use. You can also have infratentorial, and depending on location, it can be troublesome on trying to figure the type of tumor it is. But here we're seeing it go along your tentorial leaflet here, and actually a pretty common location. But we also got to think outside of the brain, right? And think about in the spine too. And has really some of the same imaging characteristics here. It has that bright enhancement that's very diffuse, right? Now in the spinal canal, mass, it's such a small area, it can be hard to try to differentiate the masses, but we can use other sets of imaging just like we did originally with the CT. And we can actually see there's actually extra bone or extra calcium in here, some hyperostosis. So that can make us more confident, yep, that's a meningioma. All right, okay, so, but how do I differentiate my differentials? Well, you know, you can think through these. So for supratentorial, when it's along the dura, you know, other things I'm going to think about are going to be Mets, and that can be breast, melanoma, lung. Mets is going to definitely be faster growing than our meningiomas. So you can, if it's the first image you see, they have a history of cancer, you're trying to decide, is this Mets or is this a meningioma? You can always do a short interval, and your Mets will definitely grow faster than, say, a meningioma. Another one probably to keep in our differentials, the hemangiopericytoma, definitely a mouthful. It's actually, you're not supposed to say that anymore. Again, who likes to change the names? The World Health Organization. So it's actually now on the spectrum of a solitary fibrous tumor. These are going to be a lot more aggressive looking than our Mets. It can be, though, sometimes hard to differentiate that from a higher grade meningioma. All right, intraventricular, what other things am I going to maybe put in my differential? Choroid plexus tumors, but usually those that actually enhance even more, and it has to deal with, they have even more vascularity than a meningioma. You have your neurocytoma. Those usually are more towards the foramen of Monroe, and usually have this multicystic soap bubble type appearance. So those can be imaging findings that you might use to help say, oh, I fear meningioma versus these. And again, we can use advanced imaging if we need to. Transosseous. Well, I think you always have to still consider Mets. Now, if you think about the two transosseous cases I showed, those both showed hyperostosis. Usually for Mets, you're going to see bone instruction instead of hyperostosis. Other things you could think about, maybe fibrous dysplasia and Paget's, but it's not really associated with soft tissue components. And that's where an MR with fat saturation could come into play and be helpful. You could do, they have them in the anterior central skull base. We saw that as our first case. Things that are in that region that you might have to think about, a pituitary adenoma. Those are usually more actually in the cell, usually a little more well circumscribed. And yeah, I said I wouldn't talk about a dural tail because we all know that, but they will not have a dural tail compared to our meningiomas. Another thing maybe in that area that you can kind of think of a craniopharyngioma. Those are more centered specifically in the suprasellar region and tend to be more cystic solid, at least for the adamantinous type. I showed you the case of the optic nerve. What other tumors can I think about being in there? Maybe an optic pathway glioma, but you're not going to have that tram tract appearance, right? Instead of being around the nerve, it's actually going to involve the nerve itself. And so the nerve itself will be enlarged. All right, infratentorial. We saw that case towards the end of infratentorial. They can be anywhere infratentorial. Where it becomes an issue is probably your cerebral or pontine angle. And to kind of differentiate that from a schwannoma, The schwannoma is going to be more centered right into that internal auditory canal compared to the meningioma. Some people say look for the ice cream cone with the ice cream on top to tell you that's a schwannoma versus meningioma. And Mets, you can probably just always put in your differential, but same rule applies to other places. And then finally, for spinal, what other things can we think of? Maybe a nerve sheath tumor. Those, when they're big enough, usually are in the foramen or extended to extraforaminal space. They don't typically calcify, so we did see on our case on the CT that did have calcification. And then, for the Mets, same rule apply again. So again, let's revisit the mystery case. So again, what the heck is this? I never make decisions on what one image set. So it doesn't really fit what we saw with the MRI yet, right? This is a lot darker than the isotense T2. So let's look at more images. The CT, okay, it has calcifications, but doesn't really have that like speckled, spotty appearance that we saw before. It has these coarse calcifications. And is that a drain there? Yeah, it is. Why is there an old ventriculoperitoneal drain? And you would think someone knew about this case, but this was an actual case where the patient had a remote surgery and we just weren't sure what this is, no reliable history. We go to our diffusion restriction. Well, maybe some components have diffusion restriction. This guy doesn't though. So we said, for diffusion restriction, it can be helpful when it does diffuse restriction, when it doesn't, not very helpful. So again, not helpful. Well, I didn't really talk about this image, but this is a SWI that really looks at blood components, and it has what I think is a lot of blood there. It could be calcium, but CT really didn't show calcium there. What the heck is this? And so then, yeah, we're getting closer to let's just rely on our post-contrast images. So this is our pre-T1, and let's compare it to our post-T1. Wait. Well, it has some peripheral rim enhancement, but not really enhancing. So in the end, I said, yeah, for my report, I said, this isn't looking like a typical meningioma. I don't think this is meningioma. Did I say this was B-cell lymphoma? No, I said this is a very weird thing. It ended up being B-cell lymphoma. So really, I hope from this talk, again, I hope you got at least one thing out of it. You might have knew some of the stuff, but maybe learn something new that you can, again, take back while you're looking at these studies and go from saying, that's a mass to saying, no, I can pretty reliably call this a meningioma. So with that, thank you so much. Again, thank you, Health for the World, for giving me this opportunity. And if anyone has any questions, I look forward to them.
Thank you so much, Dr. Ormsby. That was really phenomenal. If anyone has questions, please raise your hand or put them in the chat. I have one question for you, just to go back to basics. One of the questions I always have when I'm looking at a brain tumor case or mass is, how do I know I'm in the meninges to start out? Can you give me some hints on how to know if I'm intraaxial or extraaxial?
Yeah, so again, I said I don't want to talk to them, but I think we do have to get back to the basics too. And yeah, so things that we can look for is that dural tell sign. And what does that mean? That's basically it's going to hug the dura and kind of slope out. Whereas if it were a more of an intraaxial, it should be, if it's near the skull, kind of more rounded and not have the edges that kind of spread out basically into the dura itself. And then there's the CSF cleft sign. Sometimes you can see CSF going around on your T2 weighted images, or at least in a certain component to try to help you differentiate that. Does it work all the time? No. And are there other tumors, intraaxial tumors, that actually have that? Yeah, I can actually think of sometimes like a PXA can have the dural tell sign. Some of the others can have CSF cleft. So not 100% reliable, but yes, definitely actually one extra tool to have in your bag to try to differentiate where it's intraaxial, extraaxial. And you know as well as I do that there are cases where you're like, I just don't know. And this is too large that I'm going to use all the things I have that I talked about, but sometimes, we just don't know. And then we ask the surgeon, we place bets. We're like, I think this is more like the extraaxial. Can you tell me in the end, is it? Yeah. I think those are some of the things, but I think by using this talk, using some of those basic concepts, you can really get to decide, is this a meningioma?
Great, that's super helpful. Any other questions from the attendees? We'd love to hear from you guys in the chat or out loud.
Yeah, if not, I actually have a question for you, Dr. Sorty. So I know you're a neurointerventionist, obviously, because I work with you all the time, but can you comment on the role of embolization?
Sure. I think taking it back to basics, there are two questions for a neurointerventionalist or an angiographer. First, do we need a diagnostic angiogram? And I think prior to resection, a diagnostic angiogram is very useful. And there's a classic finding called the mother-in-law sign, where a meningioma will enhance early and stay late, just like your mother-in-law. Offensive, but true. And originally angiograms were the only modality to really diagnose meningiomas. We would look at the displacement of the blood vessels. So you want to look for the classic imaging characteristics and as a potential tool to map the vasculature for the surgeon. So you want to look at the arterial vasculature and the supply, but it's also a bit more sensitive in looking at if there are venous issues, like if the superior sagittal sinus is involved or occluded or compressed. Both MRI and angiography are complementary. So sometimes a diagnostic angiogram alone can be helpful. And then embolization plays a role. It's controversial. Some authors and interventionalists advocate embolizing most meningiomas, but it's very important to be aware of dangerous anastomoses. You certainly don't want to make a surgical candidate worse or give somebody a stroke. And so careful attention to the blood vessels and anatomic knowledge is very important. If you are going to embolize a meningioma, you need to get about 80% of it in order to make surgery faster and safer. So each case is kind of evaluated individually, but I think a diagnostic angiogram to make that decision is valuable in most cases.
Yeah, I think since I've been here at University of New Mexico, I've only seen one or two of our meningiomas actually be embolized pre-op.
I mean, I feel like I've done at least 10 cases in my case log. I just went through those. But I think it really depends on the surgeon and whether they feel like they can get good control intraoperatively. And so it has to be a conversation. But I think that the evolution is to move from more embolization to less probably. And the benefit can be unclear. So there's still a role, but I think each case needs to be discussed between the angiographer and the surgeon to decide. But yeah.
Right. And you're saying going from more to what's being done. And it might go simply back to the history of angiography, right? And angiography was actually great for meningiomas from the diagnostic component because of, like you said, the mother-in-law sign. And since this is being recorded, I want to say I do really appreciate my mother-in-law. So I don't think she's like that. So yeah. Yeah, any more questions that we might have?
Seems like we don't have any other questions, so I think we can complete this lecture. Thank you so much, Dr. Ormsby, for your time, and Dr. Sorty for moderating this lecture.
Absolutely. Have a great day, you guys. It was a pleasure.
Yeah, thank you so much. And again, if you haven't joined Health for the World, please do. Great organization. So,
thank you.